Hello guys, welcome to our channel. Today we are going to discuss about the obstetrics rapid revision as part of our mission to 100 plus. So almost we are near to the examination, more 16 days to go. I hope you are all doing the well preparation guys. Always remember, be confident about yourself. In this 15 days also, you need to give your best to score best in the last final examination. Okay. So daily practice the MCQs, read the rapid revision programs, and also don't forget to take care of your health. Eating and sleeping pattern is also important in this last 15 days. Okay, so also happy new year to everyone. I hope this year is going to give the more success in the examination as well as in your personal life also guys. So wish you all a happy new year and let's start our discussion. So here the discussion guys, we will be discussing the obstetrics part 1 today, and next part 2 the gynecology will be discussing tomorrow. So these are the known as Leopold's maneuver. Okay. So the first one is known as a fundal grip. Okay. Here as the examiner, we are going to check on the fundal side, right? This side we are going to check. What we are going to check if it is a buttocks. So how you are going to see if it is a buttocks, it is going to be soft and irregular. Okay. Soft and irregular. Next, if it is a head, it is ballotable, globular or ballotable. Likely to be the patient head is on the upper side, right? Then it is likely to be breech position, right? This is how we are going to understand. Next, so what the first grip is explaining us, it is about lie and also fetus presentation, right? Fetus presentation. Next, second grip is known as a umbilical grip or the lateral grip. Okay, this is known as a umbilical or lateral grip. So usually this will be helpful for us to know the patient where is the heart is placed. So that back is the place. No, if we see the back of the patient is just going to be smooth, okay, smooth and regular, then likely to be we can check the fetal heart rate. Okay, this will be helpful for the fetal heart rate. Next, third grip is known as a Pauly grip. Third grip is known as a Pauly grip. So here in this picture, if you see, only the single hand is placed on the pelvic region. Okay. So this is also helpful for us to understand the presentation of the fetus. Presentation, and at the same time whether the head is engaged or not. Head is engaged or not. If you still feel that the patient is globular and prim, then it is a cephalic. And if it is moving, then if it is hard again, then it is likely to be the patient is in the breech position. Okay, that's how we can differentiate. Same like a fundal grip, but only the one hand we are going to check engagement of the head also. Next, fourth, this is here, and in this three positions we are going to face the patient. Only in this we are going to face the patient legs. Okay, the differentiation that you should understand. And the fourth grip is also known as a deep pelvic grip. This is known as a deep pelvic grip. Here we are going to check the engagement again and also attitude of the fetus. Okay, attitude of the fetus. Usually this will be helpful when the patient is already engaged. Then we are going to check is the head is already engaged or not. Okay, if the fingers of both hands brought below to the fetal head, then likely to be, if you feel that, then it is not yet engaged. If you can't feel, already it is engaged. Okay, that's what we are going to understand from the Leopold's maneuver. And here some of the fertilization events that you have to understand. Okay, only the few important points. For example, spermatogenesis. Spermatogenesis is going to take place in the seminiferous tubules. Seminiferous tubules. Okay, and spermatogenesis overall, how many days it is going to take? Usually it is going to take average of the 72 days it will take to form the spermatogenesis. Whereas spermiogenesis is the transformation of the spermatids to the sperm. Overall, the fertilization lifespan will be 72 hours only. Okay, and these, if when they convert into the sperms, only the lifespan is 72 hours. Okay, in that 72 hours only they have to find out and they have to get the fertilization zygote formation. This is what the important point that you have to understand. Next, sperma capacitation. The next event is the capacitation. Capacitation is usually happened at where, guys? At the cervix region. Okay, it will start in the cervix and ends in the tube. Okay, it will ends in the fallopian tubes. And how about the capacitation time? Capacitation time is 6 to 8 hours. Okay, capacitation time is 6 to 8 hours. Next, zonar reaction. What does mean by the zonar reaction? The zonar reaction is, it is not going to send the any other sperms. Once one sperm is entered, next this zonar reaction is against all other sperms. Okay, it will block the way for all the sperms. That is for the zona reaction that you have to understand. Next, fertilization events where it is going to occur. The answer is ampulla of fallopian tube. Ampulla of the tube, that is where is this event is going to happen. Next, moving on to the calculations, some of the important calculations. For example, if you want to check the estimated gestational age, okay, or estimated delivery date, that if you want to check, what is the formula that you are going to use, guys? The common formula all over the world we use is the Naegeli's formula. Okay, Naegeli's formula. And Naegeli's formula, how we are going to apply? First, you have to take note of the first day of LMP, then plus 7 days, then plus 9 months. Okay, this is how you are going to get the formation of the Naegeli's formula. And next, another thing that you have to remember is the gravida and parity. Okay, gravida means total number of the pregnancies of the mother that is present. Okay, next we have to take note of the gravida and parity. So what does mean by the gravida? So we are going to calculate the past and also present pregnancy. Gravida means that the patient is pregnant. Next, parity. Parity means the number of pregnancies that she has crossed 28 weeks. So more than or equal to 28 weeks pregnancy is crossed, then we can call this patient as a parity. Okay, this is how parity is calculated. So gravida and parity, that you have to take note. Next, and also you also have the other things that you have to understand. A for abortion we are going to include, and also L for leaving wings. Okay, so this is how also we are going to add in the while we are going to add the scoring. So this is the basic question. Also, if they ask, you can easily answer. Next, moving on to the important signs of the early pregnancy. So from the picture here, you can see this is known as a Chadwick sign. This is known as a Chadwick sign. So what does mean by the Chadwick sign, guys? So Chadwick sign means this bluish discolorization. Here you can see this bluish discolorization of the cervix, that is known as a Chadwick sign. When it is seen, it is approximately seen at the 8 weeks. Next, here you can see another sign. This one is the Hagar's sign. Okay, what does mean by the Hagar's sign? It is softening of the isthmus, and Hagar sign is seen around 6 to 10 weeks. Okay, this image based question is also asked in the examination. Next, this is known as a Goodell sign. Okay, this is known as a Goodell sign. Big difference between the Hagar and the Goodell is, Goodell sign is the softening of the cervix. Okay, this is about softening of the cervix, and this is softening about the isthmus. And here in this picture, you are using the two hands together, that is Hagar's. Okay, and Goodell sign, you are only looking at the cervix. It can be with the help of the speculum also, that is softening of the cervix. When the Goodell sign is seen, it is the most earliest and the first sign of the pregnancy, and it is also seen around the 6 weeks. Okay, this is also seen in the 6 weeks of the time. Next, other signs, if you want to remember the other important signs, then other one is the Palmer sign. Palmer sign is the rhythmic uterine contractions. Okay, Palmer sign is the rhythmic uterine contractions. This is seen around 8 weeks. 8 weeks. And next one is the Osiander sign. Osiander sign means lateral vaginal wall pulsation. So when you are palpating the vaginal wall, you can feel the pulsation. will be seen, and this is also seen around the 8 weeks. Okay, other these important signs that you have to remember. Next, height of the uterus. So height of the uterus, usually at the 12 weeks, it will be above the pubic symphysis. Okay, it will be above the pubic symphysis. Next, 22 weeks. Okay, here. So if you see, this is the 22 weeks. So at the 22 weeks, where you are going to see exactly, you are going to see at the umbilicus. Okay, exactly, you are going to see at the umbilicus. This picture is taken from the Google, but you can trust this one. At the 22 weeks, you are going to see at the umbilicus region. Next, at 36 to 38 weeks, the fundus usually right up to the sternum. Okay, after that, again, it is going to decrease the sign, decrease the uterus measurement. Why? Because the engagement will be happening. So after the 40 weeks, what happens? It is slowly dropped to again to the below sizes. That's what's seen in the after 40 weeks. Next, immediately after the delivery. Immediately after delivery. After delivery, you are going to feel this just below umbilicus. Just below umbilicus, you are going to palpate the fundus. Okay. Next, day 2. From the day 2 of delivery. From the day 2 of the delivery, where you are going to feel. So usually the uterine height is commonly, the height will be decreased 1 finger breadth per day. 1 breath per day, it is going to decrease its uterine height. Okay, that's what from the day 2 you are going to see. All right, next, another sign is the quickening. What does mean by the quickening, guys? So the quickening is known as a perception of the fetal movement. So the mother is going to perception of the fetal movements. This is seen in the, especially when they are in the second trimester, around the 18 to 20 weeks, the mother is going to feel this one. So next we will going to see the physiological changes of the pregnancy. So in the physiological changes of the pregnancy, the things that you have to remember here is the most importantly, the pregnancy is equal to progesterone. Okay. So if the pregnancy is maintaining, the reason is the progesterone. It is always dependent on the progesterone only. Next, what are the skin changes that associated with the progesterone, or what are the other associated symptoms that is associated the estrogen we are going to see now. Next, first see the what are the responsibilities of the progesterone is holding here. First, it is going to maintain the pregnancy. It will maintain the pregnancy. Next, it is also going to decrease the peripheral vascular resistance and also smooth muscle relaxation. The smooth muscle relaxation, especially in the myometrial. So there will be a relaxation that is seen, and blood vessels also going to be relaxed. And if more progesterone is present, it can also prevent the preterm labors. It will prevent the preterm labors. Next, coming to the estrogen. So the estrogen is going to play major role in the some of the systemic changes, such as it can cause the chlasma. Okay, it can cause the chlasma and also cholestasis, and thyroid binding globulin is going to increase in the body, and also helpful for the oxytocin release. Also helpful for the oxytocin release in the body. So these are the changes that we will see with the estrogen. Next, what are the important changes that you have to remember for our pregnancy physiological changes? What happens? The blood volume is going to increase. So the blood volume is going to increase. That means that the mother is having the hemodilution, right? This is the normal thing that we are going to see. So once the blood volume is increased, plasma volume is also going to increase. And also RBC is going to increase. Hemoglobin size will also increase in the patient. Next, globulins will also increase. Immunoglobulins and other important globulins also going to increase in this patient. Next, what are the changes that is going to decrease here? Basically, the decrease criteria is hemodilution. That means hematocrit is going to decrease in this patient. Next, factor 8 and 11. factor 8 and 11 is going to decrease, and hypoalbuminemia you are going to see in this patient. Hypoalbuminemia you are going to see, and platelets, especially platelets, is going to decrease. Platelets, when it is decreased, we call this as a benign gestational thrombocytopenia that we are going to include in this call known as in this patients. Okay, that's the thing that you have to remember. Next, cardiovascular sounds. Cardiovascular sounds, CVS, what you are going to hear, S1 plus S2, and also the S1 is going to be heard as a splitting. So this is also considered as a normal. Next, S3 is also heard, still it is considered as a normal. And next, murmur can be heard in this patient. So this murmur is actually systolic murmur. Okay, this murmur is systolic murmur, and still it can be also considered as a normal in the patient. What are the other changes? The cardiac output will be increased. Okay, the cardiac output will be increased. So the heart rate, pulse rate, and the stroke volume is also going to increase. And we discussed peripheral vascular resistance will be decreased due to the parameters. What are those? What are the important factor? That is due to which one, guys? Progesterone is going to decrease the peripheral vascular resistance in the patient. Okay, next, moving on to the amniotic fluid. So amniotic fluid, the main resources for the amniotic fluid will be from the fetus only. Okay, for example, in the first 20 weeks, it is from the fetal skin. Okay, once the urogenital system is developed after 20 weeks, it is whole from the fetal urine only. So this is how amniotic fluid is maintained in the pregnancy. Next, some of the normal values that you have to remember. So the normal amniotic fluid packet index is around 5 to 24 centimeters. So we are going to check in the four sides. So how much for the single? So single, it is around 2 to 8 centimeters. Okay, 4 packets we are going to check. So at least 8 into 4 times, around 24 centimeters, that we are going to see the amniotic fluid. Next, according to the color, if we can consider, usually in the normal patients, at the time of the turn, you are going to see this as a straw color. Okay, next, green color is seen in the patients of the infection like listeria infection, or patients those who are with the fetal distress. This patient, you are going to see the green color due to meconium, or also sometimes due to fetal distress. Next, golden color is seen in the RH positive mothers. Next, also brown color, you can see this brown color is seen in the death fetus. Brown color is seen in the death. And next, dark red color. Dark red color is seen in the abruptio. Saffron color. Saffron color also can be considered as normal because it is seen in the post-term pregnancy. Next, see the difference between the oligohydramnios and the polyhydramnios. So oligohydramnios is usually due to less than 5 centimeter. Next, polyhydramnios is due to more than 8 centimeters, or it is more than 25 centimeters. Okay. Next, what is the important things that you have to take note? What are the causes for this one? So the most common cause for the oligohydramnios is due to the idiopathic cause only. Okay, it is due to idiopathic cause. Whereas same as the polyhydramnios, it is also due to idiopathic cause. But severe oligohydramnios, when the severe oligohydramnios is seen in these patients, severely oligohydramnios, as I discussed here, what is the important factor? Urine is the main role playing. So if the patient is having the oligohydramnios, that means the renal agenesis could be the other cause. Okay, if it is severe, likely to be due to renal agenesis or the fetal renal anomalies. For coming to the polyhydramnios, the urine has to be excreted only when the fetus is already drinking, but it cannot drink and it is accumulating in the uterus. Likely to be this is due to GI anomalies. Okay, this is due to GI anomalies, and example is the esophageal atresia or the duodenal atresia. These are the some of the other causes. Next, coming to here, the hypertension can cause. The patient with the hypertension can cause, and also decreased growth IUGR could be the other causes. Next, mother is taking the ACE inhibitors. This can also decrease the renal activity, or post-term pregnancies will also have the decreased type. Next, in this coming to here, it could be twin pregnancy, or it could be diabetes mellitus patient, or also this is due to Rh negativity. So all this will be seen in the polyhydramnios. Next, what could be the treatment that we have to do? So always treat the underlying cause. Treat the underlying cause. Next, what we have to immediately do? We can go for the treatment. We can give some of the other treatments, like you can give the fluid for this patient. Okay, to stabilize, you can give the amino acids or the fluids that you can give. And in this patient, we have to stop restricting the fluids. Okay, stop the fluids for the while. Okay, this will maintain over the time. That's the thing that you have to do. Next, we will be discussing about the placenta. Usually placenta is around 500 grams. It will be important for the oxygen and carbon dioxide maintenance from the mother to fetus. Okay, and how it is going to be shaped? What is the shape? Discoid shape. Discoid shape that you are going to see about the placenta, and most likely the placenta is only less than 4 centimeters. Okay, less than 4 centimeters. If it is more than 4 centimeters, then you will call this as a placentomegaly. Next, how many vessels the placenta is going to attach? 3 vessels. What are those guys? 2 arteries, left and right, and only 1 vein. And that 1 vein will be left side. Okay, left 1 vein is only present. What are the hormones that is associated? Hcg hormone is going to be present here. Next, see the sides of the maternal and the fetal. Next, coming to here, the maternal side is due to decidua basalis, and here on the fetal side, this is due to chorion fundosum. This is chorion fundosum. Next, what are the differentiation that you can easily understand from this? Here you can clearly see the cotyledons. Okay, so this cotyledons and thick blood color will be seen reddish brown color that you are going to see on the decidua basalis, because it is attached to the uterus. Next, the chorion fundosum, this will be shining, and the mid circular region, the umbilical cord will be attached. So this is shiny and gray color that you are going to see on the fetal side, chorion fundosum, with the vessels. That is on the fetal side for the identification. Next, the some of the types, other types, here you can see this is the battledore. What happens in the battledore? There will be, the cord should be in the middle, but here the insertion is on the corner. This is battledore. Next, velamentous insertion. The vessels are velamentous. Here you can see it has to be in the central, but the vessels are very far and very fragile. High chance it can broken also. Next, coming to the other succinturate lobe, the extra lobe that is present for the placenta abnormality. Next, there is also bilobed, multilobed with a single cord, that is known as a bilobe. Next, we have the circummarginatum and circumvallate. What is the difference between the circummarginate and the circumvallate? Is the both sides are the maternal. You can see the circumvallate is going to be like the valve like thickening. This thickening that you are going to see around the placenta, that is circumvallate. And here you can see there is no wall thickenings. There is no wall thickenings that is seen in the circummarginate. This is the differentiation and types of the placenta. And some of the important points about the ultrasound when we have to take note. Okay, for the usually for the NT scan, you can go for the 10 to 13 weeks. 10 to 13 weeks for the NT scan. And next, TIFA or the anomaly. So this anomaly can be done around 18 to 20 weeks. 18 to 20 weeks we can go. And growth can be done around the 32 to 34 weeks. Okay, this can be also done. Next, fetal echo. Fetal echo can be also asked in the examination. This is around 20 to 24 weeks. These are the times that you have to go for the scanning for the patients associated this anti-TIFA growth and other. Next, coming to the antenatal scans or antenatal visits, how many should? According to the WHO, it is 8, and according to the India, it is 4. Okay, these are the mandatory things that has to be done for the antenatal. Next, they have to take the TT or the TD vaccine. How the TD vaccine is given, guys? Given to all the pregnant women. How many? So it is given in the 3 different doses. The first dose is given at the first visit. Okay, and the second dose is given after 4 weeks. After 4 weeks of the first dose. That is how we are going to give. And next, the third one is going to be the booster, given if only the 2 doses of the immunization is given less than 3 years. Okay, if it is given in the less than 3 years only, then only we can go for the booster dose. Okay, this is how we are going to follow the protocol. Next, folic acid. Next, folic acid supplementation for the pregnancy woman. Where the folic acid, usually how we are going to give, guys? Basically, we are going to give 400 micrograms for all the pregnant women. For all the pregnant women, we are going to give the 400 micrograms at least 1 month before the pregnancy. 1 month before the pregnancy that we are going to start. Next, 4 milligram per day. This is given with the history of neural tube defects or patient who is suffering from the epilepsy or taking the anti-epileptic drugs. And this is started 3 months prior to the pregnancy. It is continued even after the pregnancy also for the during the breastfeeding. So around we are going to give the 4 milligrams for those patients. And diabetes patients also still the 400 micrograms is given. And only anti-epileptic and the patients those who are suffering from the history of the neural tube defects, then we are going to give the 4 micrograms as per the guidelines that we are going to follow. Next, we will be moving on to the labor pelvis and important points that you have to remember. First, here you can see this is the classification of the different types of the pelvises, guys. What is the classification that is known as the Caldwell classification? Okay, Caldwell-Molloy classification, which will be dividing the 4 types of the pelvises. What are those? Gynecoid, which is the most commonly seen in the all the females, and platypoid, this is the another least common type of the pelvis. Android, this is the second most common seen in the male population. And anthropoid, this is the another type which will be around the 20%. Okay. What is the important points about these pelvises? First, you have to understand the shapes. So the gynecoid pelvis, the shape is circular. Okay, the android is in the heart shaped, the anthropoid is in the oval shape, and the platypoid will be irregular. Okay, platypoid will be irregular type of the shape. Next, what is the usually for this we have to take note what is the presentations. So gynecoid, the most commonly the cephalic presentations all will be done by the gynecoid, and for the platypoid there will be face presentation, most commonly associated with the face presentation. Next, android patients, you are going to see the occipito posterior. Occipito posterior is commonly seen. Next, anthropoid type. In the anthropoid type, you are going to see the persistent occipito posterior we are going to see. Next, another things that you have to remember is the transverse diameter and anterior posterior diameter. So the transverse diameter is more here. Transverse diameter is more than the anterior posterior diameter. And same as android also, there the transverse diameter is more than the anterior posterior diameter. Whereas anthropoid, here the anterior posterior is more than the transverse. Next, platypoid. In the platypoid, the transverse diameter is only more than the anterior posterior. Only thing that you have to remember is the anthropoid, which will be more with the anterior posterior. Next, what about the ischial spines? Ischial spines are more prominent with the android. Remaining all not that prominently we are going to palpate. So this is the things that you have to remember, guys. Gynecoid, we know every time we are going to see the most females will be gynecoid and remaining all are going to be considered under the cephalopelvic disproportion that we are going to see. Most commonly, the cesarean is only can be done for these people. Next, moving on to the pelvis and their whatever the dimensions, diameters that you have to remember. Next, if you see the maternal pelvis is divided into the three segments. One is inlet and other one is the cavity and then outlet. Okay. So inlet is lies inside the level of the pelvic brim. Next, cavity lies at the level of the ischial spines. Next, outlet at the level of the ischial tuberosity. Okay. So first we'll see the what are the important diameters that you have to remember. For the patients of the inlet, you have to take note about the three types of the conjugates. What are those? So the first one will be the true conjugate, and next obstetric conjugate, then diagonal conjugate. So these conjugates will help us to understand what is the differences. So the true conjugate here in this picture, here you can see this is the true conjugate, guys. So the true conjugate is telling us from this is the sacral promontory. From there to the pubic symphysis, it is around 11 centimeters. Okay. So it is around 11 centimeters. Next, obstetric conjugate. Okay. Here, what is the obstetric conjugate? It is around again, the sacral, here the sacral promontory to the mid pubic symphysis. Okay. To the mid pubic symphysis. This is around 10.5 centimeters. Next, diagonal conjugate. Here you can see this is the diagonal, same sacral promontory to the tip of the pubic symphysis or the lower border. This is around 12 centimeters. Okay, these things that you have to remember. Next one is the cavity is going to have the two planes. One is the greatest pelvic dimension, and in this greatest pelvic dimension, everything will be 12 centimeters. Okay. Next, another one is the least pelvic dimension. So here you are going to have average of the 11 to 12.5 centimeters. Okay. Next, in this also we are going to have transverse diameter. This transverse diameter is only 10 centimeters, which is very smallest. Next, moving on to the outlet, guys. Outlet is usually outside, right? So outside here, where we are going to start at the pubic symphysis and then tip of the coccyx and also the laterally of the tuberal ischial tuberosity we are going to see. Next, outlet, the important things that you have to remember: AP diameter around 13 centimeters and transverse 11 centimeters. Okay, these are the important points are the measurements that you have to remember for this. Next, coming to the presentations. So how we are going to see the patient presentations. So the presentation parts is divided here in this picture. Here you can see this is the three different types. So the most common presentation is always a cephalic. Okay, but other type of the presenting parts, for example, here you can see this is the vertex, most common, and then this is the brow. Okay, you are going to palpate the eyebrows, and this is the face presentation. And how these are presented. Why vertex is seen here? Because the head is flexed. In this position. Next, brow, it is extended. So the partial extension of the head is seen. Next, face presentation is fully extended. Next, cephalic position. What is the treatment? The NVD. The natural vaginal delivery is recommended. Same as the head also. So we are going to proceed for the vaginal delivery. But brow position, we are going to proceed for the LSCS. Okay. There is a high chance head is extended, high chance for the injury. That's why we are going to proceed for the C-section. Next, coming to the face. In this face also, we have the two different types. One is if the patient is having the mento anterior, then we can proceed for the vaginal. And if it is mento posterior, then you have to proceed for the CS, okay, cesarean section that you are going to proceed. Next, position. These are the different types of the positions that you are going to see. Right occiput anterior. So our right is left here and our left is right here. So this is right occiputo anterior. So anterior means towards the pubic symphysis. Next, here it is left side, left again occiput on the anterior side. So left occiput posterior, right? The pelvis opposite to the coccyx side. So then it is posterior. So this is how we are going to interpret the position of the fetus. Let's see different stages of the labor. Okay. So we'll discuss now about the labor, and here we are going to discuss about the different types of and different stages of the labor. So first we have the two different, one is latent and another one is the active. So latent phase is around 4 centimeters. So up to 4 centimeters of the cervix dilation, then it is considered as a latent. Next, if it is more than 4 centimeters and up to 10 centimeters, considered as a active labor. Okay, this is the first thing that you have to see. And latent is started by the event of cervical effacement and cervical dilatation completes by the active labor. This is how we are going to see. Once this 10 centimeters is dilated, then we are going to proceed for the delivery of the baby. This is first thing that you have to remember. About the timings of the latent and the active. So latent is usually 20 hours in the first pregnancy and less than 14 hours in the patients of normally when they are going to have the multiparity, it is less than 14 hours. Next, coming to the active labor, it is based on the less than 1.2 centimeter per hour. Again, this is in the first parity. Next, 1.5 centimeter per hour in the second or the multi-parity. This is how the normal labor timings will be seen in the patient. Next, we also have the abnormality labor, like abnormal labor. In this first one, the prolonged latent phase. So the prolonged latent phase, when we are going to define this, the prolonged latent phase more than 20 hours in the primary or more than 14 hours, it is seen in the patients of the multiparous. So then it is considered as a prolonged latent phase. What is the treatment that we are going to give? Usually we are going for the rest only. Okay, we are going for the rest only. Unless or until if it is CPD or cephalopelvic disproportion or unfavorable condition, then we can go for the patients for the C-section. Next, protracted active phase. Protracted active phase. So in this one, this is actually slow progression. What does mean by that? Less than 1 centimeter per hour. So it is still in the same centimeters only. The dilatation is not increasing than that. Then it is considered as a protracted labor. Or else less than 1 centimeter fetal head is also still at the same position. Then we can consider this as a the descent is also it's still in the same position, then we can also consider this as a protracted active phase. So what we have to do, we should do the PV examination. After this, you have to go for the per vaginal examination. So in this, you are going to check the hypotonic. Is it the hypotonic? Is it the hypotonic or the normal? Hypotonic means the contractions is less or normal. So if it is less, then you can proceed for the oxytocin administration. Okay, this is one thing that you can give. Next, if it is normal, then wait and watch. Again, if it is CPD, then we can go for the C-section. Next one is the arrest in active phase. Arrest of active phase. So what does mean by the arrest of active phase? It is diagnosed if membranes are ruptured, like ruptured membranes is already done, but still even though despite of that, more than or equal to 4 hours, the cervical dilatation is still same, then it is considered as a arrest of the active phase. What we can do for this patient is, if the uterine contractions is normal, then we can go for the oxytocin can be given. But or else we can go for the treatment of the cesarean section only. So the treatment is cesarean section. Despite of the oxytocin, more than 4 hours, cervical dilatation is still arrested, then go for the C-section. Next, last one. This is the second stage. This is known as a second stage or the prolonged second stage arrest. So what does mean by this? So first, nulliparous woman more than or equal to 3 hours, she does not have any kind of the changes in the cervical dilatation, or multiparous woman more than 2 hours, still in the second stage only. So there is no change in the dilatation. Then also we can go for the cesarean section for this patient. Okay, this is the thing that we are going to proceed as per the patient's associated condition. Right? Next, what about the management of the labor? Okay, what about the management of the labor? Usually what we are going to do, we are going to monitor the labor from the partograph. This is the modified partograph where we are going to plot active phase or the latent phase, every centimeters, fetal heart rate and contractions per minute, and how many oxytocin that we are given, and what other drugs we are also going to given. So this everything will be monitored from this partograph where we are going to monitor the condition. This is the normal delivery movements. Okay, this is the cardinal movements that we are going to understand. What are these? First, every decent, remember by the mnemonic of every decent female employee rises extremely late. Okay, extremely late. What does mean by that? So the first one will be engagement. So here you can see the first one is the engagement. Next, descent for the descent. Next, female is for the flexion of the head. So where you are going to see, so the flexion of the head will be seen here. Okay, the flexion of the head. Next here, after this, there will be rotation. So what kind of rotation? This rotation will be internal. Next, employ. This employ is the extension of the head. Once the baby is out, the extension of the head will be seen. Already the baby is out. The complete extension will be seen here. Next, rises means restitution. So it will come back to the normal position. Like after the extension, it will be completely turning the head to the normal. That is the restitution. Next, extremely external rotation. External rotation. And next, lateral flexion. Lateral flexion. So these are the cardinal movements that is seen in the normal delivery. So you have to remember about the third stage of the labor guys. We already seen the first stage latent, second stage is the active. This is the third stage about the placenta delivery. Okay, this is about placenta delivery. For this, we are going to follow the active management of the third stage of the labor, which is known as the AMTCL guidelines from the WHO. What is this? They are going to include the 4 important steps. The first step is going to give the injection of the oxytocin. Okay, give the injection of the oxytocin immediately within the 1 minute of baby delivery that you have to give. Especially IM, you have to give on the shoulder. Next, second one, delay the cord clamping. Immediately you don't have the clamp the cord, delay the cord clamping. Next, third one is the delivery of the placenta. How we are going to delivery? With a controlled cord traction. Okay, with a controlled cord traction, you are going to deliver the placenta. Immediately you should not remove the placenta as much as we are the commonly doing the mistakes is you should not immediately move. And next, do the assessment of the tone. Okay, do the examination or the assessment of the uterine tone that you are going to check. These importantly 4 steps that we are going to do for the immediately after the third stage or the placenta delivery. Next, you can also know about the purpurum guys. So in the purpurum, we have the 3 types. One is the lochia rubra. The what is this? This kind of the sequence, the shedding of the decidua we are going to see. First, lochia rubra in the red color. Okay. Then serosa. This is in the yellow color. The next, alba, the white color. Okay. Alba in the white color. This sequence is also asked in the examination. So this is immediately less than 24 hours. This is more than 4 days and it is more than 10 days. We are going to see. Okay. How again uterine involution, what we discussed guys, immediately below the umbilicus you are going to see. Below the umbilicus you are going to see after the delivery. And from the day 2 you are going to see one breath. Okay, one breath per day you are going to see it is going to decrease with height. Next, we are going to moving on to the systemic diseases during the pregnancy. Importantly, first one is the pregnancy induced hypertension. So defined as if the patient more than 20 weeks of the gestation and they are likely to be having the more than 140 by 90 mmHg on the two occasions. Okay, on the two occasions. How many hours? At least 4 hours apart, two times. If you see the same, that is considered as a gestational hypertension. Okay, next, if the patient is say more than 20 weeks, again more than 140 by 90 mmHg, 4 hours apart, two times, but this time the patient is having the other signs also. For example, proteinuria you have seen. Then this one known as a preeclampsia. Preeclampsia. But if the mother is less than 20 weeks and say more than 140 by 90 mmHg, then it is likely to be this patient is suffering from the chronic hypertension. Okay, chronic hypertension. That means before the pregnancy only she had that one. Next, again less than 20 weeks, more than 140 by 90 mmHg plus proteinuria. This condition is chronic hypertension. Chronic hypertension with superimposed with superimposed preeclampsia. Okay, this is the classical definitions that you have to remember. First thing, next, moving on to the types. Okay, what is these types that we have discussed importantly? Gestational hypertension, preeclampsia, chronic, and the superimposed preeclampsia. So, what does mean by the preeclampsia? Preeclampsia can be differentiated from the two types. Okay, preeclampsia, if it is associated with the only BP, only proteinuria, then more than 140 by 90 mmHg. So this is considered as a mild. But if it is more than 160 or more than 180 or even more than 200 with any of the diastolic more than 90 mmHg, the two in the 15 minutes, 15 minutes to occasions, 15 minutes to occasion with the systemic signs. What are the systemic danger signs that you are going to see? For example, this can be associated with the HELP syndrome. Okay, or the patient is having the headache, like eclampsia signs can be seen, or right upper quadrant pain, the liver injury can be seen. All this will be considered as a severe eclampsia. Okay, severe pre-eclampsia that we are going to see. Next, what is the pre-eclampsia? What does mean by the eclampsia? Eclampsia is known for the just the patient is having the hypertension plus the generalized tonic-clonic seizure known as a eclampsia. And what is the treatment or the prevention that we are going to give for this patient? Only thing that you are going to give is a magnesium sulfate IV that you have to give for this patient. Okay, this is the thing that you have to remember. Next, coming to the risk factors. So the risk factors, usually what could be the risk factors, guys? The femaleness, okay, the femaleness, first one, and the priming gravida first time, and father, the paternal genes also going to play role here. Twin pregnancy, diabetes mellitus patient, RH negative pregnancy, and also those who are suffering from the molar pregnancy, and more age, extreme age can be risk factor, and also lower age can be also risk factor in this patient. and obesity due to the high resistance for the patient, and these conditions will be associated with the hypertension. Okay, next, what is the pathophysiology? The pathophysiology is generally the syncytial trophoblast and the trophoblast proliferation is occurring. That is the main cause for the pregnancy induced hypertension. Next, what is the prevention that we can give for this patient? The prevention is aspirin. Okay, the oral aspirin can be given for this patient. The prophylactic dose will be around 100 mg per day. This is the prophylactic dose we can give. So when you can start 12 weeks of the pregnancy, that you can continue up to the 34 to 36 weeks of the pregnancy. Right? This is the first thing that we are going to do. The next, management. When it is comes to the management or the treatment of this patient, the PAH patients, what you are going to do is the first thing, if you see the patient is suffering from the pregnancy, what we discussed, it is already more than 20 weeks of the gestation where they are diagnosed with the hypertension. But if they are associated with the eclampsia, already they have one seizure, or they are showing the signs of the seizure or organ damage, multiple organ damage and organ end damage that you are seeing, then what you have to do is, first line is give the emergency drug labetalol. Labetalol should be given, and along with that MgS44 dose should be given for this patient. And if the mother is between the 28 to 34 weeks, if the mother is 28 to 34 weeks, then we also have to give the steroids. Patient, after, even if you see this patient with a HELP syndrome, okay, what does mean by the HELP syndrome, guys? The elevated levels of the liver enzymes. Okay, liver enzymes is elevated. And next, low platelets. Okay, low platelets. So these two things considered as a HELP syndrome, and for this patient, immediately you have to do termination of the pregnancy. After giving all the prophylaxis doses, then termination of the pregnancy is done. But if the mother is mild, only the mild PAH, then we can, as long as 37 weeks, we can consider and we can go for the delivery. Okay, this is the protocol that we are going to follow for this patient. Next, for the MgS44, we are going to use the pre-chart regimen commonly of over the 14 mg that we are going to give, IM and IV. Combinedly, this can be given for this patient. 2 buttocks we are going to give. And next, coming to that, what are the hypertensives that we can use for this patient? Usually the first line will be labetalol, emergency drug. For the all the emergency cases, we are going to use the labetalol. If they're still not working for the labetalol, then we can go for the hydralazine. Okay, if they are asthmatic patients, then we can go for the methyl dopa calcium channel blocker we can use for this patient. And other drugs for the chronic hypertension, to maintain the doses also we can maintain for the methyl dopa only. Okay, this is how we are going to give. But what are the drugs that are contraindicated in this patient? Those drugs are ACE inhibitors, we are not going to give. ERK inhibitors are drugs we are not going to give. And also diuretics. Diuretics also not given in this patients. These three should not be given for this patient as a dosage. And also, if the patient is showing the signs of the toxicity, for the MgS44, calcium gluconate will be given. Okay, calcium gluconate as given for the antidote. Next disease is diabetes mellitus. Diabetes mellitus is divided into the overt diabetes mellitus. That means it is pre-gestational, then the patient is already suffering from the diabetes. Next, other one is the gestational diabetes mellitus. So what is the difference for this both patient? Usually the overt diabetes mellitus is the diabetes mellitus females who are conceived with the diabetes status. Okay, so from the day one of the pregnancy, they are going to be the diabetes mellitus only. So these patient, the gestational diabetes mellitus, after 24 weeks of gestation, there is a high chance insulin resistance will be seen. Okay, due to the physiological changes, there is a high chance for the insulin resistance will be seen in this patient. Around 24 to 28 weeks this will be seen, and before the pregnancy or first trimester they are not diabetic mellitus. Okay, only after 24 weeks they are a significant increase in the insulin resistance. Okay, first thing. Next, what is the criteria that we are going to follow for this patient? For the overt diabetes mellitus, the fasting blood sugar should be more than 126 milligrams per dl, and HbA1c should be more than 6.5 grams. Okay, so this is for the overt diabetes mellitus. We are going to consider this criteria, right? And another commonly criteria that we are going to follow is the DIPSI guidelines. What does mean by the DIPSI guidelines? This is for the gestational diabetes mellitus. For the all the patient, for the first antenatal visit only, for the first antenatal visit, you have to do the fasting blood sugar. Okay, fasting blood sugar should be done for this patient. Again, after 24 to 28 weeks also, you have to repeat with the HbA1c. This is the guidelines that we have to do. And what is the thing that we are going to do for this DIPSI guidelines? OGTT. What does mean by the OGTT? Oral glucose tolerance test. How much? 75 grams of the glucose in the 300 ml of water we are going to give for this patient. This glucose water should be given for this patient. Okay, for the 5 minutes. And after 2 hours, then after that you have to check the 2 hours timeline. So if the 2 hours of the timeline is more than 140 milligrams per dl, then this is considered as a gestational diabetes mellitus. Okay, and if it is more than 200 milligrams per dl, then this is considered as a overt diabetes mellitus. Okay, on the first visit itself you can go for the this test should be done for the patient. First protocol and the guidelines that we have to follow for our patient. Next, what is the treatment? How can we do? So HbA1c is the best factor. This is the best test that we can perform to check the congenital defects. Okay, why? Because hyperglycemia is directly proportional to the defects. So highly toxic and teratogenic for the baby. That's why we are going to do this one. If the HbA1c is 15% high, then there is a high chance congenital defects will be associated with this patient. Okay, so target anomaly or the TIFA scan is must and should we are going to do for this patient. And what are the complications we will discuss. Before that, what is the things that you have to do? The first thing that you have to do is the therapy. For the coming to the treatment, if the patient is gestational diabetes mellitus, first line will be diet. Okay, the diet restriction should be done for this patient. And if the diet restriction is not done properly, then after 2 weeks, then still you have to repeat the OGTT. Okay, you have to repeat the OGTT. Then if the OGTT shows more than 200 milligram or more than 120 to 140 milligram, then you have to go for the insulin therapy. Okay, direct insulin should be given for this patient, and insulin should be usually given in the subcutaneous form, and most commonly used is the human insulin. Okay, still gestational diabetes, first line will be dietary or the lifestyle modification only. And second, if it is still not controlled after 2 weeks, do the OGTT, then insulin should be changed. For the overt diabetes mellitus, always insulin. Always insulin should be given for this patient. Next, management of the patient and how we are going to manage this patient. Basically, if the patient is gestational diabetes mellitus, when we are going to terminate the pregnancy more than or equal to 39 weeks, we can go for the delivery. Okay, but if the patient is not controlled well, if the patient is not controlled diabetes mellitus, then we can go for the 37 weeks of delivery. Okay, 37 weeks of the delivery should be done for this patient. Next, overt diabetes mellitus patient. Overt diabetes mellitus patient, same as like that, we can go for the 37 weeks of delivery. Okay, 37 weeks of the delivery we can go, because 37 weeks what we see, lung maturity will be seen in this patient. That's why we have to go for the 37 weeks or equal to 37 weeks of the delivery should be done for this patient. Next, coming to the complications. What are the complications seen in the fetal? Okay, in the fetal complications, usually if the mother is having the hyperglycemia, immediately after the birth, the baby will be having the hypoglycemia. Okay, the mother will be having the hypoglycemia and hypokalemia, hypomagnesemia. These three parameters will be seen. Along with that, respiratory distress syndrome, or congenitally the patient will be having the heart diseases, right? There is a high chance the patient will be developing the VST, or also transposition of great arteries will be seen in this patient. Next, other than that, you are also going to see the macrosomia. Macrosomia is also seen in this patient, and necrotizing enterocolitis will be also seen. Next, coming to the maternal complications. What are the maternal complications we are going to see in this patient, guys? The high chance they are going to transmitted by the vaginal infections. Okay, commonly the whatever the glycosuria is going, that will cause. Next, hypertension will be seen. Okay, hypertension will be associated. Abruptio can be seen. Polyhydramnios. Okay, polyhydramnios will be seen, and premature rupture of membranes and intrauterine death, or IUGR, will be also seen. Usually we think only macrosomia, but IUGR can be also seen, and abortion can also occur in this patient. Okay, and highly these all complications will be seen with the patients of the diabetes mellitus. So next topic we will be discussing about the twins, guys. So here you can see, based on the placenta and the amniotic separation, we can understand what type of the twins that we are seeing. So first let's discuss with the dichorionic or the dichorionic and the diamniotic. So here what happened, there is a fused placenta. Okay, the placenta is fused for them. This is dichorionic and the diamniotic. Okay, so for this patient, what we can understand is, usually they are associated with the same or same sex, or sometimes different sex. Most of the time same sex only. Okay, and how many layers are present? 4 layers are present for this patient. Okay, 4 layers, right? Next, and always there two placenta will be present here. Okay, two placenta will be presented. And what is the sign that you are going to see? The sign you are going to see on the ultrasound will be twin peak or lambda sign. Twin peak or the lambda sign that you are going to see here. Right? Always this is the most common, and good prognosis will be seen in this patient. Good prognosis is seen. Next, coming to the dichorionic, diamniotic, what happened here? There is a separate placenta here which is present. This is the fused placenta and this is the separate placenta. Mostly they look like fused, but always it can be two placenta. Okay, almost same. Same sex will be seen here. 4 layers only seen, and also twin lambda sign commonly seen in this, and both are associated with a good prognosis only. Now we are going to discuss about the monochorionic and the monoamniotic. There is only one layer. There is only one layer and single placenta. Okay, but high risk for the cord entanglement. Okay, cord entangling will be seen in this patient. Next, sometimes highly risk for the conjoined twins also. Conjoined twins also seen in this patient. That's why we go for the C-section whenever possible, like 30 to 34 weeks, we can go for the surgery for this patient. Next, last one, monochorionic diamniotic, and here the most of the times will be the patient is associated with the only the layer that is differentiating is the amniotic only. The chorion will be same, and here in this patient single placenta is present. Okay, single placenta, and here we are going to see the T sign. T sign is seen on the ultrasound. What does mean by the T sign, guys? Single chorion with no intervening placenta. That is what T sign. Okay, and but they are associated with the twin to twin transition syndrome. Twin to twin transfusion syndrome. Monitoring is important for this patient. Only immediate delivery is needed for this patient, which is monochorionic monoamniotic. And we have to understand these patients where how they are going to be presented and what is the division which will be causing here. For the dichorionic and the diamniotic, if the division is less than 4 days, they are going to develop as a dichorionic diamniotic. Next, same as here also, if it is less than 4 days, then likely to be this is associated with the dichorionic and the diamniotic. When it is comes to the monochorionic monoamniotic, the fertilization and every process is done less than 9 to 12 days. Monochorionic diamniotic less than 4 to 8 days. Okay, this is for the monochorionic diamniotic, the timing of the divisions. Okay, coming to the conjoined twins, as I mentioned here, most common conjoined twins, the most common conjoined twins will be paraphagous. Okay, paraphagous is the most common. And we all discussed what are the complications from all the twin pregnancies commonly will be associated with the transfusion syndrome, twin transfusion syndrome. Okay, and another one is the anemia polycythemia syndrome, anemia and polycythemia syndrome, and other one is the arteria IUGR will be seen. Okay, IUGR also seen. This is twin transfusion syndrome, and here it is twin anemia polycythemia syndrome. IUGR will be seen in this patient. Next, what is the first thing that you have to remember about the twin transfusion syndrome? The twin transfusion syndrome will be, they are two twins. Okay, one is the donor twin, other one is the recipient. So what does this donor twin will do? It will be giving the blood to the recipient. So there is a chance with the anemia here, and here it is the polycythemia. And giving the blood, there is a oligohydramnios. Here polyohydramnios will be seen. Here renal failure will be seen because of the patient is low anemia. And what happens here? There will be a risk of thrombosis. High blood flow is seen in this patient, and heart failure will be seen here, and same as here, heart failure will be seen due to lower anemia, due to fluid overload. That is what twin transfusion syndrome. What is the staging they use for this patient? Usually the staging will be Quintero. Quintero staging will be used for this patient. What is the treatment that we are going to do? If they are less than 28 weeks, we can do the ablation. Okay, we can go for the ablation for this patient. If it is more than 28 weeks, if it is more than 28 weeks, then we can go for the delivery. One fetus will be normal and other fetus is likely to be died. Next, coming to the delivery, the management for the delivery of this, normally the twin patient, how we are going to proceed? Always we are going to proceed for the vaginal delivery first choice. Okay, first choice will be vaginal delivery only, regardless. Only the cesarean section is done for the patients with the monochorionic and the monoamnionic or conjoined twins, because high risk for the complications. That's why only these will be done. Remaining all will be vaginal only. But when we go for the vaginal delivery, if the baby is normal, we can go for the delivery until 38 weeks. Okay, 38 weeks we can go. Then what about the delivery? If the first twin is cephalic, then go for the vaginal. Okay, if it is a second twin is breech, next breech associated delivery is done. Assisted breech delivery we are going to proceed. And if the first cephalic, another scenario, the first is cephalic, but the second is lie, transverse lie. Then again here you are going to do the, normally you are going for the vaginal. Okay, then second one you can go for the internal podalic version. Then proceed for the breech. This is done for the twins. Okay, this is the first scenario. Sorry, this is the second scenario, and here it is first scenario we are going to do. And always remember, you have to do the immediately, you have to do the vaginal delivery regardless of the cephalic. Okay, cephalic should be done vaginal only. Only the second twin depends, is it the breech or is it the line? Then only we are going to proceed for the as per the terms. Okay, if the internal podalic version is not done, then we can go for the cesarean section also. Now we will discuss about the RH incompatibility. So let's see. What does mean by the RH incompatibility? Immediately when the mother is pregnant on the first antenatal visit, what you have to do? You have to check the mother-father status. Okay, mother and father status. If the mother is RH negative but father is RH positive, so 50% of the chance the fetus will be also RH positive. Okay, RH positive. So these mismatch is known as a RH incompatibility. Then what you have to do? You have to proceed for the indirect Coombs method. Indirect Coombs method. And if the indirect Coombs method is positive, then this is known as a RH immunized, RH isoimmunized, RH isoimmunized pregnancy. Okay. Then if it is negative, if it is negative, then it is RH non-isoimmunized. Then what is the treatment protocol we are going to follow? If ICT is negative, means that likely to be, what we have to do? Again, these negative should be repeated after 28 weeks. And if it is still negative, then what we are going to do is we are going to give the RH anti-D prophylaxis we are going to provide for this female. And how much is the dosage? 300 microgram we are going to give. And after immediately the delivery should be done around 39 weeks of the gestation. Okay, 39 weeks of the gestation should be done. And another point that you have to remember is the early cord clamp should be done. What I said in the AMTSL guidelines, delayed cord clamping, but only RH negative pregnancies, we have to do the early cord clamping should be done for this patient. Okay, then after the baby is already born, then you have to check the baby's direct Coombs test. Direct Coombs test. Okay, and in this direct Coombs test, if it is negative, then you have to give the again anti-D prophylaxis postpartum, anti-D prophylaxis postpartum to mother. It should be given accordingly. This is how RH incompatibility and the protocol and the treatment should be done. Now let's see, indirect Coombs test is positive. Okay, indirect Coombs test is positive, guys. What we have to do? Then we have to check for the antibody titers. Okay, if it is more than 1.16, 1:16, then you have to go for the MCA Doppler. Okay, MCA Doppler should be done. And if this MCA Doppler is more than 1.5, okay, more than 1.5, likely to be fetal anemia is present. Okay, fetal anemia is present. Then you have to proceed for the chordosynthesis. The sampling should be taken. And the fetal blood, when you are taken from the chordosynthesis, you are going to check the hematocrit, right? Hematocrit less than 30 or hematocrit more than 30. So more than 30 means only the monitoring will be done. Every week you are going to do the MCA into every 1 week, and then you can go for the 38 weeks of vaginal delivery. Okay, this is done for the hematocrit more than 30. If the hematocrit less than 30, but the gestational is more than 35 weeks of age of gestation, then what we can do is terminate the pregnancy. Okay, terminate the pregnancy. If it is less than 35 weeks, we have to do the intrauterine blood transfusion. Okay, intrauterine blood transfusion should be done for this patient, and you have to wait more than 35 weeks. If it's already 35 weeks, then you can go for the delivery of this patient. What is the complication that we see with this patient? Likely to be hydrops fetalis, right? Hydrops fetalis we are going to see. Hydrops fetalis syndrome that will be associated with the Rh negative pregnancy. And always the first criteria for this hydrops fetalis is you are going to see the ascites in the baby, ascites, pleural effusion, and pericardial effusion. At least any two is present, then we can consider this patient as a hydrops fetalis. And also hydrops fetalis is associated with the non-Rh causes. For example, anemia that is associated with the parvovirus, aplastic crisis can be seen, and also commonly with the cardiac diseases. Okay, most common. These are the causes that we are seeing with the hydrops fetalis. Next, we will discuss about the antepartum hemorrhage. So the first condition for now we'll discuss about the antepartum hemorrhage. Here you can see this is the first condition. So this is vasa previa, guys. Okay, in this patient, usually no symptoms will be seen. Okay, no bleeding and also no pain abdomen will be seen in this patient, but mild spotting will be seen. What is the condition due to placenta abnormality? Okay, usually the velamentous insertion of the cord, will be causing this one. So the fetal distress will be seen in this patient. Okay, due to the blood compression or the blood loss from the fetal side, so there will be fetal distress will be seen in this patient. What is the treatment protocol? Immediate termination of the pregnancy and go for the cesarean section. That is the treatment protocol for the vasa previa. Next, moving on to the placenta abruptia. What is the common symptoms we see? Pain, abdomen, and also painful bleeding. The patient will be having the painful bleeding will be seen because this is most commonly associated with the trauma or those who are taking the smoking like conditions will be seen in this patient abruptio. And the bleeding is also dark red in color will be seen. There are the two types. One is the concealed hemorrhage, other one is the leaking hemorrhage. Okay, this is the concealed type and another one is the visible type. If it is a concealed, it can go into the uterus, which will cause the uterine apoplexy, opposite condition, which will be seeing the trauma will be seen. But why these patients will be very risky? Because they are highly associated to develop the DIC. Okay, the complete disseminated coagulopathy will be seen in this patient, most commonly associated with the abruptio. What is the treatment that should be done for this patient? Usually, if vitals are unstable or patient is having the distress along with the fetal, regardless of the AOG, whatever the AOG, you have to go for the cesarean section. Okay, but if the vitals are stable, fetal distress is not seen, then if it is more than 34 weeks, then you can go for the labor. Normal induction of the labor should be done. And if it is less than 34 weeks, then expectant management is prompted. Expectant management will be proceeded for this patient. Next, coming to the abrupt previa here. This is the condition of the previa. So there are four types of the previa, guys. What are those four types? Here you can see this is the type 1 from the os less than 2 centimeters, and this is the marginal type, and this is partially closing, and this is completely closing. So what is the symptoms that we see here? There is no pain abdomen and no pain, but there is a present of bleeding. Okay, so we can say this is painless bleeding is seen in this patient. Painless bleeding is seen. So this is considered as a warning sign, and which will show the red color. Okay, not dark red, but it is seen as a brick red color will be seen. Okay, this is seen in this patients. Next, the uterus is also going to be soft. Upon palpation, it is going to be soft and non-tender in this patient. So for this patient, what we are going to see is the one of the criteria, and what is the sign that we see here is the Stalwarthy sign. Okay, Stalwarthy sign. What does mean by this Stalwarthy sign? Usually the placenta previa patients will be seen when the placenta is on the posterior side. Placenta is on the posterior side, we are going to see this stalwarty sign. Again, regardless of the AOG, if the patient, regardless of the AOG, and if the vitals is unstable, then distress is also seen, then we have to proceed for the cesarean section should be done as a treatment. Again, here, if the patient is having the normal vitals, okay, vitals are normal, then what we can go for here is the do the abdominal scan. Ultrasound should be done. And what is the ultrasound we have to go? Transvaginal ultrasound should be done for this patient. And if the patient is normal, okay, then we can go for the McAfee regimen. Okay, McAfee regimen we have to follow. What does the mean by this McAfee Johnson regimen, guys? Always you are going to proceed for the what we are going to do, NST test we are going to do, biophysical profile we are going to see, and regular monitoring, antenatal visits, and fetal distress is present or not. All these are going to be seen in this patient. Then we can proceed until 36 and we can proceed until 37 weeks of the gestation to 39 weeks. Then we can go for the for this patient. Okay, this is the expectant management. And if it is not again unstable, then again we are going to proceed for the transvaginal ultrasound is also showing abnormality. Then we have to go for the LSCS for this patient. Okay, this is the treatment protocol that we follow for the Previa patients. Next, here we are going to discuss about the placenta accreta spectrum. Okay, what does mean by the placenta accreta? Here you can see the placenta invaded. Partial myometrium is invaded. Okay, next in the increta, most and complete invasion of the myometrium is seen here. Next, percreta, very rare, and this is associated with the other organs also. Okay, like urinary bladder or the pouch of Dulgus serosa, that is also included in the percreta. Okay, that is seen with this here. Next, what is the most common cause for this patient? The most common risk factor for this is the present pregnancy, but history of previa in the previous pregnancy. That is the one. And another one is the previous history of cesarean section. That is also another cause will be seen. The most common cause is the present pregnancy with the history of previa. That is the one thing. What is the common cause here? The pathophysiology here is there is a Nita Butch layer. This layer will be presented between the decidua basalis and our uterus. If this layer is absent, then there is a high risk for production of this accreta syndrome. What is the management that we are going to do? The management for this patient is the delivery. Okay, vaginal delivery should be done. And after that, if it is not done, then we can go for the LSCS. Okay, maintain the pregnancy and do accordingly vaginal or the LSCS. Then the only treatment is hysterectomy. Hysterectomy should be done for this patient. Now we will be discussing about the postpartum hemorrhage, guys. Usually, if it is more than 500 ml from the vaginal delivery, or if it is more than 1000 ml from the cesarean section, then we can consider this as a postpartum hemorrhage. If it is less than 24 hours, it is early, and if it is more than 24 hours, it is late postpartum hemorrhage. The most common cause will be uterine atony. Okay, most common cause will be uterine atony. So the tone that is not decreased, which is going to cause the severe bleeding in the patient. What is the first thing that you have to do here? First, resuscitate the patient. Firstly, resuscitate the patient. Immediately, you have to go for the massage. Uterine massage should be done. After that, and if you see still the patient is not getting to the normal, okay, then you have to go for the bimanual massage, and along with that, you also have to give the drugs. What are the drugs that you are going to give, guys? We will discuss after this, but you have to give the drugs. If it is still not controlling, then you have to insert this one. What is this one? This is known as a Bakri balloon catheter. Okay, this is known as a Bakri balloon catheter. And even though if it is also not controlling, then we can go for the surgical sutures. Example, B-linked sutures will be done. B-linked sutures will be done commonly, and even though it is also not controlling the, then we have to go for the ligation. First step, uterine ligation, uterine artery ligation can be done, okay, or ovarian artery, where still if it is persisting, then we can go for the subtotal hysterectomy. Subtotal hysterectomy should be done. If it is still, then we have to go for the complete pelvic pressure pack should be given, or parachute or the umbrella pack will be done. Okay, this is the protocol that we follow for the uterine atony. And what are the drugs? What I discussed here, the drugs. The drugs that commonly not used here are the not used is dinoproston. We don't use commonly. And next one is the carbitocin. These are not used. And remaining oxytocin, okay, oxytocin, and also some of the important drugs like methargine, carboprost. These drugs can be, or the misoprostol, okay, misoprostol. These drugs can be used for the controlling of the bleeding for this patient. Okay, this is the first thing. Next, here you can see this is the uterine inversion. This is uterine inversion. So prolapse, this is the uterus that is prolapsed. This is the placenta. So what we have to do? So this is the emergency, guys. This is the emergency condition. What we have to do? The most commonly, this is actually mismanagement by the particular person who is delivering. So there is a high chance that this patient can be going into the neurogenic shock. Okay, immediately there is a risk for the neurogenic shock. So after that, there is a hemorrhage which will be leading to the hemorrhagic shock. Okay, hemorrhagic shock. So the cause of death will be hemorrhagic shock only. But first, initially, they will be leading into the neurogenic shock. So upon the examination per vaginal, you are going to see globular mass. Okay, and per abdomen, you are going to see the depression, because the fundus is already out. The fundus is depressed, means completely came out. This is the first thing. Then what is the treatment protocol? First, immediately resuscitate and stop the oxytocin. Stop the oxytocin because it can increase the tone, right? So you have to stop the oxytocin. Then you have to use the Johnson technique. So what is this Johnson technique is? Try to insert the uterus. Okay, insert the uterus inside manually. Manually, guys. So even though if it is also fail, then we have the abdominal surgery. Okay, abdominal surgery is done. And even though if it is also fails, then we can go for the hysterectomy again. But if it is successful, then we have to stop the tocolytics, whatever we are giving the drugs, tocolytics, and remove the placenta and resuscitate. Start the oxytocin and whatever the fluids is needed, give those for this patient. Next, moving on to the some of the other important topics, guys. Shoulder dystocia. Okay, shoulder dystocia we are going to discuss now. More than or equal to 1 minute, the head is not delivered. The head is not delivered. What we can do in these patients? First, go for the episiotomy. Then immediately after that, we are going to proceed for the Mc-Roberts maneuver. Okay, we are going to proceed for the Mc-Roberts maneuver. So Mc-Roberts maneuver here, this is the Mc-Roberts maneuver, guys. What you are going to do, you are going to hyperflex the legs to the abdomen, and then you are going to give the pressure with the anterior shoulder on the abdomen. This is how we are going to give the pressure. Okay, this will help for the suprapubic pressure, able to deliver the head as soon as possible from the whatever the restricted area. This is the shoulder dystocia. Okay, and then even if it is still not coming, then you can go for the another maneuver. This is known as a wood corkscrew maneuver. Wood corkscrew maneuver. What we do in the wood corkscrew maneuver, guys? So usually in the Woods corkscrew maneuver, what we are going to do here, you can see you are going to enter the head, okay, enter the hand to the head, and you are going to rotate this. Okay, you are going to rotate the baby and turn the head to two different sides, and then you are going to proceed for the delivery. Okay, that's how we are going to delivery. Even though it is also not done, then we are going to proceed for the Gaskins maneuver. So here you can see this is the Gaskins maneuver. All the four arms, okay, all the four arms uh, on the table. Then the mother should be on the posterior position. Then we are going to bring the baby out. So this is the Gaskins maneuver. Okay, this is how we are going to proceed. And from these questions, the most common complications in the baby will be Erb's palsy. Most common nerve is injured in the mother. That is going to be the lateral cutaneous. Next, moving on to the breech delivery. Okay, in the breech delivery, here you can see there are the three types. What are those? Complete breech, frank breech, and footling breech. The foot is came out. And here in the complete breech, what happened? The both hip and the knee are flexed, right? Complete flexion. In the frank breech, the knees are extended. The knees are extended. And what is the importance of the breech? This is the most common malpresentation. This is the most common malpresentation is seen. Most commonly, the cause will be prematurity. Due to prematurity that we are going to see. And investigation of the choice for this patient will be ultrasound. Usually ultrasound will be done. And the treatment is early as soon as possible. 39 weeks we can go for the LSCS. 39 weeks we can go for the LSCS for this patient. And high risk, this footling breech will be having the high risk with the cord prolapse. Footling breech, and best prognosis will be done by the complete breech. So we can try for the vaginal delivery. What are the criteria for the vaginal delivery? Usually the mother should be 36 weeks of gestation. Then either it could be complete or it could be frank. We can go for the delivery for the vaginal only. Okay, and there should be no history of previous cesarean section or no history of any bleeding disorders. Okay, then only we have to proceed for the patients with the vaginal, and you have to always ready with the cesarean section setup. Next, what are the maneuvers we use? This is the cord traction. Sorry, this is the groin traction, guys. This is known for the groin traction, controlled groin traction we are going to use for the flexed breech. Next, this is known as a pinard maneuver. This is known as a pinard maneuver, where you are going to, this legs is extended right at the knee region. For these patients, we are going to use, especially with the two fingers at the popliteal fossa. And next, this one is known as a Burn Marshall maneuver. This is known as a Burn Marshall technique. And in this one also, especially after coming, the whole body is came, but the head is not coming. For this patient, for the head delivery, we are going to use this Burn Marshall technique. What we are doing here, Burn Marshall technique, we are actually flexing the body to upward side. Then we are bringing the baby outside. This is the Burn Marshall technique. And this one, here you can see, this is the Prague maneuver. So this is the Prague maneuver, guys, and this is for the patient those this back is on the posterior, whose back is on the posterior. For the head delivery, we are going to use this one. Okay, and here completes our today's discussion of the obstetrics, and remaining important topics will be discussed tomorrow. Those who are new to this channel and this video, please do subscribe and share with your friends. Until then, happy preparation, guys. Do your best and be confident, and you are all going to clear this examination. Once again, Happy New Year and a happy preparation.